Um, as you probably know, historically there has been some concern and then hesitancy among physicians, about prescribing the statins, especially patients with the chronic liver disease, particularly in cholestatic liver disease condition like a PBC. And even though the multiple studies have shown that statins are generally safe, but that concern still influences everyday clinical decision making. So our findings help move that conversation forward in our study, which focused largely on stable patients with PBC, which means most of whom were receiving UDCA already and had preserved the liver function. And statin use was not associated with any harm in our finding. And in fact, it was associated with, again, the low risk of future liver decompensation. But important thing to note is it's very important to emphasize that this is just a still observational evidence. You know, Even though we took great care to emulate the randomized trial and try to reduce bias as best as we could, this study alone should not be interpreted as just a proof, confirmation that statin should be prescribed specifically for liver protection. What I do think our results strongly support is just a reassurance, kind of. Clinicians should feel more confident that statins do not need to be withheld in patients with stable PBC or other types of the chronic liver disease when there is clear indication for cardiovascular protection or just a lipid lowering purpose. And additionally, in terms of the guidelines, I would expect that this kind of evidence to just contribute a gradual, shift in tone away from just the caution driven by fear of the hepatotoxicity. And I think we should approach based on risk benefit, you know, import, standpoint. And lastly, confirmation our finding by the randomized trial would be, of course, the ideal. However, again, conducting a large long-term randomized trials in this type of rare disease like a PBC is sometimes impossible and it considered very challenging. However, thankfully, there is an ongoing multi-center randomized trial leading by Professor Raymond Zhang and Mass General Hospital, and who is another co-corresponding author of this paper. And the trial plans to examine whether certain statins, may have beneficial effect in chronic liver disease, not limited to the PBC, and it actually includes a more broad indication. So our study helps provide a real-world rationale for why those future randomized trial matter. Um, I think there are a couple of steps we have to pursue. The first one is strengthening the causality. And then I've already explained about how we approach it to our study. And we employ the target trial emulation to strengthen the causality, even though that is not 100% perfect. And of course, the causality can be confirmed by the randomized trial, which is actually going on now. The second aspect I'm considering is we need better phenotyping, understanding whether statin benefits differ by fibrosis stage, biochemical response to UDCA, the current standard of the treatment, or concomitant metabolic risk factors would help identify patients most like the benefit. And the next one is mechanistic studies are also important. Statins have a well, described anti-inflammatory or sometimes anti-fibrotic effect, but we are not 100% sure. We are not that certain how these pathways interact with, autoimmune cholestatic injury in PBC. So it should be further investigated. And the last one is, even though we deal with as composite outcomes, including the liver cancer, especially the hepatocellular carcinoma, but it may be worthwhile to figure it out whether the statin may also has chemopreventive effect in reducing HCC hepatocellular carcinoma in specific patients with the PBC. Together, I see that this study as just a strong, just a signal generating step that opens the door for both, clinical trials and more refined observational analysis. Um, I think the when you think about the potential beneficial effect from the statin, and then there are lots of study, as I mentioned before, there are lots of study already published, already explored in the patients with the chronic liver disease, including every field of liver disease. But the real disease like a PBC or sometimes autoimmune hepatitis, because of their very low incidence and the prevalence, and those areas are still to investigate further. So even though we do not uh, directly uh, extrapolate from one study, you know, based on a certain disease, certain liver disease to another study based on other types of liver disease, uh, cannot generate the strong evidence for that. So I think someone need to figure it out. This result can be reproduced in this type of very rare disease, but it requires just one center database might not sufficient. So like just MGB database, which includes actually almost 11 hospitals in near Boston area. So to figure it out in those type of rare disease, we have to merge. We have to make more effort to merge the large database to ensure we have a sufficient number to investigate.